Hello, everyone, and welcome to the Transverse Myelitis Association's Ask the Expert podcast series. Today's podcast is entitled Understanding Spinal Cord Strokes and Other Vascular Myelopathies. My name is Sam Hughes, and I'll be moderating this podcast. The TMA is a nonprofit organization focused on the support, education, and research of rare neuroimmune disorders. You can learn more about the TMA at myelitis.org. This podcast is being recorded and will be made available on the TMA website for download via iTunes. During the call, if you have any additional questions, you can send a message through the chat option available with GoToWebinar. For today's podcast, we are pleased to be joined by Dr. Nicholas Zalewski and Dr. Olwen Murphy. Dr. Nicholas Zalewski is a specialist in neurology and neurohospital medicine. His clinical focus includes expertise in management of multiple sclerosis, autoimmune neurology, and rare spinal cord disease. Dr. Zalewski's primary research interest is investigating clinical and radiographic findings that help improve the accurate diagnosis and optimal treatment for patients. He possesses a strong research interest in challenging myelopathies, transverse myelitis, vascular myelopathies, atypical demyelinating disease, autoimmune neurology, paraneoplastic neurological diseases, and neuroimaging. Dr. Olwen Murphy received her medical degree from University College Dublin in Dublin, Ireland, and completed a neurology residency at the Royal College of Physicians in Ireland. She is a James T. Lubin Fellow at the Johns Hopkins Transverse Myelitis Center in Baltimore, Maryland, under the mentorship of Drs. Carlos Pardo-Villamizar. Dr. Murphy's research is on predicting outcomes after a diagnosis of transverse myelitis using current imaging techniques and spinal fluid analysis. The goal of her research project is to identify patterns or biomarkers that can be used in day-to-day clinical practice to identify benefits from therapies and help make better decisions about care. Welcome, and thank you both for joining us today. So as we dive into this topic of spinal cord strokes and vascular myelopathies, I'll ask Dr. Zalewski to start us out and help lay a foundation. Could you please just start out giving us a definition of a spinal cord stroke versus the definition of a vascular myelopathy?
Yes, and thank you for inviting me. Just to briefly kind of put into context, a spinal cord stroke, or what we term a spinal cord infarction, would be an acute focal or a small area of disruption of blood supply to the spinal cord, resulted in rapid severe symptoms and signs of a spinal cord process from that level involved from the lack of blood supply. Similar to a brain stroke, where there's an acute or a sudden focal disruption of blood supply in the brain that causes neurological symptoms, the same thing can happen in the spinal cord with a sudden disruption of blood supply to a focal area of the spinal cord with correlating symptoms. Now, vascular myelopathy is a more broad, encompassing term that would imply a disorder of the blood vessels affecting the spinal cord, whether it's the blood vessels in terms of a venous disorder, or the veins, or the arteries, or a vascular malformation. So various blood vessel disorders that can affect the spinal cord would be more encompassing term of the use of the term vascular myelopathy.
Thanks. That's very, very clear, I think, and kind of the difference between the two. I think most people are pretty familiar with the concept of a stroke, of course, more common in the brain, like you said. So as we are thinking about a spinal cord stroke and vascular myelopathies, especially in the context of transverse myelitis, or at least as transverse myelitis patients, or the community is thinking about this. Dr. Murphy, could you explain a little bit more what the signs and symptoms are of the spinal cord strokes or vascular myelopathies, especially thinking of what the signs and symptoms are of a transverse myelitis?
Sure. Well, the good thing is that in recent years, we've got a much better understanding of the different kind of signs and symptoms that spinal cord strokes can have versus a transverse myelitis, for example, which would imply an inflammation in the spinal cord. patients who experience a disruption of the blood supply resulting in a spinal cord stroke or infarction typically have symptoms that develop very rapidly over minutes to hours. Another common feature at the onset of the symptoms is pain in the back. And most commonly, the legs are involved in terms of the neurological symptoms. Patients frequently have weakness and loss of power in their legs, and sometimes numbness and tingling as well. Because the nerves supplying the bladder and bowel function also travel through the spinal cord, a stroke can result in a loss of function of the bladder and bowel as well. So those kind of symptoms are what people with a spinal cord stroke might experience, and there are some slight differences from patients who might have a transverse myelitis or an inflammation problem in the spinal cord, which typically develops a little bit slower, for example, and may not be as severe at the onset of symptoms.
Right. In terms of other vascular myelopathies, is there, in thinking of a spinal cord stroke and what you just described for signs and symptoms, are there other types of vascular myelopathies that are, I guess, strikingly different, at least from the onset of symptoms?
Yep, that's correct. So there's sort of two broad categories of vascular myelopathies. The vascular supply to the spinal cord is made up of arteries, which bring the blood to the spinal cord, and veins, which take the blood away or drain it away from the spinal cord. Problems usually occurring in the arteries cause infarction or stroke, whereas there can be problems in the veins or abnormal connections between the veins and the artery, which results in impaired drainage of the veins from the spinal cord. And this sort of has an effect like putting a plug in a sink and the sink overflowing. The spinal cord becomes swollen and suffers those kind of problems. So patients with those problems with the veins or venous problems of the spinal cord tend to have slightly different symptoms. That's usually a slower process that can evolve over days to weeks or even months. And that would be typically a progressive problem where patients are experiencing more symptoms as time goes on. And typical problems might be some weakness in the legs, some difficulty with walking and exercise, problems with balance and falls, and then eventually maybe stiffness of the legs and difficulties with bowel or bladder function. So the important aspects in terms of differentiating those problems based on the clinical story is that typically venous problems are more slow to evolve than arterial problems or strokes.
Right. It's a very nice way to differentiate the two. And hearing you describe kind of the slower progression of a venous problem, a problem with the veins in the spinal cord as a vascular myelopathy, compared with the description of a potentially slower progression of symptoms for transverse myelitis, would you say that there's similarity from an onset between those transverse myelitis and a venous problem with the spinal cord?
Yeah, I would definitely agree with that. And interestingly, many patients with venous problems of the spinal cord take many years to come to the right diagnosis because it is a rare disorder and it can look like many other things. And the most common thing that patients with venous problems of the spinal cord are diagnosed with is transverse myelitis, because the symptoms look very similar, and in some cases the MRI also looks very similar. So they can be difficult things to differentiate.
Right. And thinking about the diagnostic process, Dr. Zalewski, as we're thinking about spinal cord strokes and vascular issues with the spinal cord, whether they be arterial or venous, what are the diagnostic criteria or things that you're looking at, or specific diagnostic testing that you would use to work up a patient where you're concerned where there might be a vascular issue versus an inflammatory issue, and it's hard to tell through MRI or just from clinical review?
Yeah, so great question. Specifically in terms of spinal cord stroke or spinal cord infarction, we have recently proposed a set of diagnostic criteria, which does help put this in perspective for physicians to more confidently and accurately arrive at a diagnosis of spinal cord infarction versus another cause, such as a specific transverse myelitis. And really, the importance of this criteria is it doesn't rely on one specific thing. It really relies on the history of symptoms, the MRI, and spinal fluid showing a non-inflammatory profile. So the main makeup of the criteria for diagnosing spinal cord infarction that we have proposed, that patients develop severe rapid deficits or severe rapid neurological symptoms corroborated by the neurological exam within 12 hours or less. They have an MRI that is consistent with a spinal cord stroke, sometimes with very specific findings. And then they have a spinal fluid that generally almost all the time is non-inflammatory, doesn't show those findings of inflammation or oligoclonal bands like somebody with multiple sclerosis would have. And then most importantly, however, is having an expert clinician review to make sure that there isn't a more likely alternative diagnosis once all the information clinically and diagnostically has been gathered. So kind of collectively using all the clinical presentation, the MRI and the CSF is really important, and then looking for those specific markers of spinal cord stroke on the neuroimaging by review with an expert neuroradiologist. It's pretty much the way we approach the diagnosis. Now, I will say with that, if I have a very good historian right away of a symptom gradually progressing over the course of a week that is not a severe deficit, the patient does not have a spinal cord infarction, and I really won't go into the diagnostic criteria. It really heavily relies on, as Dr. Murphy pointed out, a very rapid acute presentation of severe neurological symptoms affecting the spinal cord to kind of even put things in the context of considering a spinal cord stroke, and that's why obtaining the history accurately is so important. Then as a side note, other vascular myelopathies, for example, the most common of which would be another venous disorder, as Dr. Murphy pointed out, particularly a condition called spinal dural fistula would be the most common one we encounter, would usually be a bit progressive spinal cord disorder over months to years in the vast majority of cases, with typical imaging findings of that disorder, and then confirmation with blood vessel imaging, where we look and see the abnormal tangle or connection of blood vessels that's causing the disorder of the spinal dural fistula.
Yeah. Yeah, that's very clear. It sounds like it's the diagnostic criteria where you're thinking about transverse myelitis or spinal stroke and these myelopathies is kind of an evolving process as we're learning more and have better technologies. That it's important to kind of review the criteria and continuously think about it. Would you agree with that statement, Dr. Zalewski?
Absolutely. I think just as support of that, for example, with multiple sclerosis, we've had diagnostic criteria out for decades, and it continues to get revised, and there continue to be tweaks and modifications to try to help, because it's not always clear, even in this disorder where we understand at a much higher frequency as well, the diagnosis is not always straightforward. So I think taking steps forward to further define and accurately diagnose spinal cord stroke or spinal cord infarction is kind of an important step that I think multiple of us have been trying to work on to help put things in perspective and differentiate from transverse myelitis and the associated diseases that are specifically diagnosed when an inflammatory disorder of the spinal cord is suspected. Because I think it's very important that patients know the accurate diagnosis, and we're not just saying, oh, well, it could be transverse myelitis. Here's the treatments that we often use for transverse myelitis. I just don't think that's a good step forward at this day and age in medicine, and trying to be more specific with what we're doing.
Yeah. And so, Dr. Murphy, kind of in this vein, how common is spinal cord stroke? and especially as it's compared to transverse myelitis or other of these rare neuroimmune disorders that our community is more used to hearing about. Can you speak to the prevalence of these kinds of vascular myelopathies, and then speak to what the expected prognosis is for someone with a spinal cord stroke?
Sure. Well, spinal cord stroke is an uncommon disorder, but it perhaps is not as rare as it previously was thought to be. It's now appreciated that in the past, some patients were not diagnosed specifically with a spinal cord stroke, and it was thought that they just had transverse myelitis, for example, or another spinal cord problem. With the improvements in recognizing this disorder in recent years, we've looked back at a large group of patients seen in Johns Hopkins Transverse Myelitis Center, and of around 800 patients who were referred as having a diagnosis of transverse myelitis, it turned out that around 20% of them actually had a vascular myelopathy after we did a complete evaluation. So it does seem clear that these are disorders that have been missed in the past and perhaps are a little bit more common than people think. However, they still are rare disorders. The difficulty is it's hard to exactly quantify these things. So we really don't know, for example, how many people in the US are affected by spinal cord strokes over 1 year, and it's not really possible for us to come up with an exact number at the moment, but perhaps something we could work towards in future. And regarding the second part of the question about the prognosis for somebody with a spinal cord stroke, for example, we always say that with any patient with a spinal cord disorder, the essential tools for recovery are rehabilitation, rehabilitation, and more rehabilitation. So most patients will experience some improvement with rehab, although the extent of recovery does vary from person to person. On one hand, we have seen patients return to active lifestyles of running and hiking after a spinal cord stroke. In other cases, patients have required the long-term use of a wheelchair, for example, due to walking difficulties. But the important elements in the recovery process after a spinal cord stroke are rehabilitation. Obviously, a positive attitude can be very helpful, and support of family and friends is very useful for our patients.
Yeah. And does spinal cord stroke affect both adults and children, or is there a specific kind of demographic, whether it be age or anything else, that would clue you into that this might be a spinal cord stroke as opposed to a transverse myelitis or another issue, Dr. Murphy?
Well, in Johns Hopkins, we have treated patients from age 4 months old to 90 years old with spinal cord strokes. So it is something that can occur across the lifespan. However, it does look like there is a period of life when they may be more common, which is similar to strokes which occur in the brain. It looks like for spinal cord stroke, the peak time of incidence might be between the ages of around 50 and 70. And this is a common time in life to experience various problems relating with vascular disorders, such as heart attack and stroke and things like that. And this is a time in life also when things tend to catch up with people, like high blood pressure, high cholesterol, obesity, smoking, and various factors that can increase the risk of having vascular problems in general.
Yeah, so it sounds like, so just going back to what you both have described in terms of the different types of vascular myelopathies, from more of the stroke side, the infarcts versus the malformations, is it fair to say that maybe the younger cases are due to more of the malformations because of some congenital issue, or is that not necessarily a correlation? Dr. Zalewski, would you like to answer that?
And a great question. I totally agree with everything that Dr. Murphy said regarding kind of the wide age distribution and who can be affected. I think when we're still specifically referring to spinal cord infarction or spinal cord stroke, the vast majority of those patients, in my experience, do not have an underlying arterial malformation contributing to the cause of the spinal cord stroke, if that's the specific term that we're using. I think that it's incompletely understood what is contributing to strokes that in patients that are younger, that don't have traditional vascular risk factors. But there are a few particular causes that I think are under-recognized, in those two most common causes that I think are under-recognized in those that are younger would be arterial dissection and fibrocartilaginous embolism. So people that have trauma or genetic susceptibility to tearing of their blood vessels, for example, in their neck, with whether it be sneezing or strenuous activity. I think these little tears that can cause a rip in the blood vessel can contribute to a clot formation and then propagation to the spinal cord, causing the symptoms, which we have seen in a high number of patients here at Mayo Clinic. And then also this incompletely understood mechanism where the actual disc that lies in between the spine vertebra under high pressure can likely, in sort of a bizarre way, come out and into the actual vasculature of the spinal cord through the veins or the arteries and cause a stroke that way. So, I think there's probably people that genetically are more susceptible to those particular entities, especially when we're dealing with very young people. And then there's many other causes of spinal cord stroke, whether they have a hypercoagulable or a blood clotting disorder that contributes and otherwise. But on the other end, people can have arterial venous malformations or an abnormal connection between the arteries and veins that can cause a variety of different vascular myelopathies, which that in particular is most common between those 20 to 40 years of age and can happen at a variety of ages.
Oh, well, that helped explain or helped answer the next question I was going to have. What's the cause of spinal cord stroke? But it sounds like, as we think about transverse myelitis, that we're more used to discussing in the TMA, and I think it's, the understanding the cause of transverse myelitis is a ongoing question, ongoing exploration. It sounds like there's really more understood about what are the potential underlying causes of vascular problems with the spinal cord than a true inflammatory transverse myelitis. Is that a fair statement, Dr. Zalewski?
I think things have developed a lot in recent years in both areas, in the areas of inflammatory myelopathies or transverse myelitis and in vascular myelopathies. I think in terms of inflammatory myelopathies, we are getting much better at identifying specific causes for transverse myelitis. So instead of just saying this is a general sort of inflammatory syndrome, we are getting better at naming that specific inflammatory syndrome. So, for example, anti-MOG, antibody-associated disease, MOG, which some of our listeners may have heard of, is an antibody that's been identified in recent years. And some patients who may have just been labeled as having transverse myelitis in the past can now be provided with a specific diagnosis, for example, of anti-MOG, antibody-associated myelitis. So I think things are definitely moving forward in the field of transverse myelitis as well as vascular myelopathies. But I do definitely agree that with vascular myelopathies, we're getting a better understanding of how to identify these disorders, the types of patients they occur in, and the possible underlying triggers for them.
Okay. Yeah, that's a good explanation, and thinking about, like you said, anti-MOG and the other, the growth in the inflammatory neuroimmune research is also, I would say, helping both worlds of the inflammatory disease world versus the vascular disease world, just helping to parse out both of them, get a little bit more granular and detailed. And kind of a follow-up question to that, it's kind of everything that we're hearing from you guys together. It seems like thinking about vascular myelopathies and vascular issues with the spinal cord, are there any preventive measures one can take against these? I mean, it sounds like a lot of it could be related to kind of general cardiovascular health. that I think most people are pretty well aware of. But is there anything different or more specific that one can do to help prevent spinal cord stroke or other vascular myelopathies? Or is there any way one could even know if they're more prone to it other than maybe having a family member who previously had some kind of issue? Dr. Zalewski, could you speak to that?
Yeah, good question. I think that's naturally a lot of the questions that we have when we hear of something that can be such a devastating and severe disorder that affects people. But I think the main thing is kind of, as you mentioned, would be really the only thing that we could do is minimize our vascular risk factors, which we all know would be good for general health measures as well, and helping prevent the more common cardiovascular disease complications of heart attacks or strokes in the brain and otherwise. And by doing that, I think in general, people that have less vascular risk factors are going to be at less of a risk of developing a spinal cord stroke. Now, again, I think there's an incompletely understood mechanical aspect to a lot of spinal cord strokes that we just don't completely understand yet, some of which are via this mechanism of tearing of the blood vessels. So obviously avoiding high velocity manipulations of the neck and things like that, but we can only avoid things like that to some extent. We all kind of have life to live, and we do activities that make our neck turn in various positions. So there really isn't anything, I would say, preventative from that standpoint, but other than avoiding things that are pretty common sense anyways, with rapid movements in the neck in strenuous ways. But other than that, there really isn't a great preventative measure, and certainly nothing that we would have data to support to prevent spinal cord infarctions. And then we really don't know with the other vascular myelopathies. There's genetic syndromes associated with some of the vascular malformations causing issues, but then in other issues, there might be previous trauma or surgery to the back that could be an increased risk for something like a venous disorder, like a dural AV fistula, but really nothing great otherwise from a preventative standpoint, other than in general, just general control of vascular risk factors and living a healthy life with a healthy diet.
Dr. Murphy, do you have anything to add to that?
No, I think Dr. Zalewski has given a very good summary that really the best thing any of us can do at the moment to try and prevent vascular problems in general is to live a healthy lifestyle, aiming for a healthy weight, exercise, eating well. And as we get older, it is really important to see a primary care provider regularly to keep an eye on our blood pressure or cholesterol and any risk for diabetes. But other than those general things, there aren't really a huge amount of things people can think of specifically regarding preventing spinal cord strokes.
I guess as a follow-up question, just thinking about it now, and just in the context of cardiovascular disease in general, cardiovascular disease runs in family, and you think more about, heart attacks and strokes in the brain, and preventive measures for those. And I guess more commonly having those issues run through families. Is there any reason to think or evidence that suggests that, if strokes in the brain run in the family or heart attacks kind of in general with cardiovascular disease, could you throw spinal cord stroke in there as well? Or is there some difference between the kind of the family heritability of strokes in the brain versus strokes in the spinal cord? Dr. Olwen or Dr. Murphy, can you speak to that a little bit? Is there anything to say to that?
I think we don't really have that information at the moment because these are rare disorders that are sort of being continually refined in terms of their diagnosis. We haven't had the privilege, I guess, of studying large populations of people over many years to see what the risks, for example, of family members of people with a spinal cord stroke are. But I suspect that the risk would be similar to other vascular disorders. So, for example, in a family, if there's a lot of history of heart disease, of stroke, of vascular problems in the legs, peripheral vascular disease, these things tend to go together. And there may be predispositions to developing vascular problems in general, rather than developing a vascular problem in a specific place in the body, like in the brain specifically, or the spinal cord. So I think possibly in families where vascular problems and heart disease and strokes in general are quite common, perhaps those families may also have a risk of spinal cord stroke, but really that's a hypothesis at the moment.
Yeah, yeah. Dr. Zalewski, is that, do you have anything to add to that statement?
No, I agree with that, and I would just reiterate as well, for the listeners, that when we are talking about spinal cord strokes right now in this context, we're kind of referring to the ones that come out of nowhere, or what we refer to as spontaneous spinal cord infarctions or spinal cord strokes, because the most common cause of spinal cord stroke is usually associated with a surgery, most typically with an aortic surgery, where the surgeons are dealing with the blood vessels that come off the aorta and supply the spinal cord. So again, general measures to prevent typical aortic atherosclerotic disease, typically smoking and other cardiovascular risk factors, is really kind of getting down to the main cause of spinal cord strokes. I just wanted to highlight that as well, that we kind of separate them into two different entities, and we've mainly been talking about the spontaneous ones, but the most common would be ones that are associated with after a surgery, most commonly an aortic surgery.
Yeah, very interesting. Yes, kind of switching gears a little bit and getting kind of adding on to a statement that was made earlier about the recovery process after spinal cord stroke or vascular myelopathy, and really even a transverse myelitis as well, and maybe helping to parse out between a TM and the spinal stroke. Through the recovery process, I think it was Dr. Murphy alluded to that the recovery can be very different from one person to the next in the long-term prognosis. But is there any maybe definition of what you as a provider would describe as full recovery from TM or spinal stroke? Would you expect it to be different between someone with a true transverse myelitis versus a spinal stroke? And kind of over time, is there kind of a time frame you look at that's kind of a magic time frame, 5 years, 10 years, 20 years? Dr. Murphy, could you elaborate a little bit more on that?
Sure. Well, I guess I'd start by saying that most patients who have had any spinal cord problem, whether that was from transverse myelitis or a stroke or other type of vascular myelopathy, is that with rehabilitation, most patients will have some improvements. But the extent of the recovery definitely varies from person to person. And part of that is really because the severity of injury to the spinal cord varies with different types of processes and in individual people. So you could have a very severe transverse myelitis, for example, or you could have a mild stroke. So each disorder will have its own spectrum. It's probably fair to say that patients with spinal cord strokes tend to have quite severe symptoms at onset, often with a lot of leg weakness or paralysis. So in general, some of their symptoms can be more severe than a lot of patients with transverse myelitis. But still, the potential for recovery is there, and particularly with rehabilitation, which does involve goal setting and then reassessing and modifying those goals of progress. As you allude to, it is a long process. So we tell our patients not to expect gains necessarily to occur over days to weeks, but really over months to years. And a lot of people in the past were told that, for example, a year after a spinal cord event, that's as good as you're going to get. But I think in recent years, we have a much better understanding of rehabilitation and how that can promote recovery after spinal cord injury, and that there is really no end point to which we can say to patients, oh, you've reached the end of the line now, and that's as much recovery as you're going to make. So we always encourage people to continue with exercise and rehabilitation for many years after their event, just to promote their recovery and their health and their conditioning. Some patients will make a full recovery. Other patients will still have some long-term difficulties. But we really don't have good long-term data to know what the outcome overall is for patients with spinal cord strokes, as this is a rare disorder that, as we have mentioned, was previously underdiagnosed. So a lot of these patients haven't been tracked for long periods.
Yeah, that you spoke to one of the questions that came in, kind of to the question of what can I continually be doing to regain back what was lost, that they've been able to do over the course of the last few years of some particular patients. And so it sounds like you've stated over and over again this afternoon, rehab, and not giving up even after a couple years. And it can be a slow potential regain of ability or what have you over time. Is there, along with kind of general physical therapy, physical rehabilitation, is there any more specialized treatment that someone with a spinal cord stroke could utilize, maybe to help relieve some of the nerve pain or other of those more symptomatic issues associated with the spinal cord stroke? Dr. Zalewski, could you speak to that?
Yeah, I think the typical neuropathic pain medications that we use, for example, with people that have painful peripheral neuropathy associated with diabetes or otherwise, we often do use for people that are suffering from kind of the residual burning nerve pain that unfortunately is fairly frequent after having a stroke of the spinal cord, more so than other disorders that have affected the spinal cord. So often using gradual increases in high doses of those nerve medications like gabapentins, Cymbalta, pregabalin, and other things in that category, we often will use for patients. Also, we've had some brief experience too in using spinal cord stimulators to help patients with refractory neuropathic pain after suffering a severe damage to the spinal cord from either a spinal cord stroke or transverse myelitis or otherwise, but definitely reiterate the importance of ongoing rehabilitation in that regard.
All very good information. There's a question that really came in from somebody listening now, getting back to kind of a definition question. Dr. Zalewski, could you speak in a little bit more detail to define what a fistula is?
Absolutely. So a fistula is when there's an abnormal connection between the artery and the vein directly, usually right near where the nerve root is itself. So kind of in this area called the neuroforamen, or kind of the lateral sides of the spinal cord, there's a direct abnormal connection where the artery feeds right into the vein in that area. And then, as Dr. Murphy was implying, when that happens, and we don't really know why that always happens, if there's previous trauma or surgeries that may make that more likely, but when this artery is causing blood flow directly into the vein, then the whole vein system is all congested and blocked up. So then the spinal cord can't normally drain its blood supply, and so it can get large and swollen. And then patients usually have progressive symptoms affecting the spinal cord over the course of many months or years associated with that.
Okay, thank you for that. I think that clarifies things a little bit more. Some of these terms, as I think we're aware of, can be a little confusing and can be very similar to each other. So thank you for that. There's a question that came in that I think is a pretty interesting question. This is a patient who was diagnosed with an idiopathic TM, considered a one-time only TM about 15 years ago. And they say that they eliminated a lot of other potential causes. And they were able to regain some walking back after that, left with nerve damage. But in a recent visit with a neurologist, they said that they're still having a hard time to tell if it was an actual stroke of the spinal cord instead of the general transverse myelitis. The issue here, and I think is the interesting question, is that MRIs from the original episode don't exist, and the medical records aren't around from that time, so they're not really much help from the actual event. Is there any way, this far out from the actual event of a spinal cord stroke or even a transverse myelitis, to be able to use technology today to look back and see if you can better understand what is the actual cause of the spinal cord issue? Dr. Murphy, could you speak to that?
Sure. Well, I guess from what Dr. Zalewski was saying earlier, there's a few things that are important for us in terms of defining a diagnosis and usually identifying people with spinal cord stroke. There are elements of the history that can be useful, such as whether the symptoms were very rapid and severe at onset. The other thing that's very important is an MRI from the time the event occurred. That's probably the most useful test in terms of identifying a pattern of a lesion in the spinal cord that could be compatible with an infarction or a stroke. So those images can change over time in people who've had a stroke. So say 10 or 15 years out from the event, there may be a hint from the MRI that yes, this was a stroke to begin with, but in other cases, it can be difficult to tell this many years later whether the initial event was inflammation or a stroke. So the MRIs from the time are usually the most useful ones. Spinal fluid as well can be helpful, but again, if that information is not available from a previous event, that's going to limit our interpretation. So this is a relatively common scenario that we see in the clinic, is that a patient comes maybe years after an event, and in some cases we can have an idea that this may have been a spinal cord stroke based on the history the patient tells us and maybe the MRI findings, but it's hard to be definitive many years after something like this.
Dr. Zalewski, do you have anything to add to Dr. Murphy's statement?
Yeah, I agree with everything that she said in that regard. I think sometimes it's it can still be seemingly somewhat more straightforward in some patients that just give a really clear timeline of symptoms that came on very fast with very severe symptoms, and you're almost always right away in that category where you say, geez, almost regardless of what the imaging looks like, this really sounded like a spinal cord stroke and not inflammation of the spinal cord with transverse myelitis. But sometimes that's quite hard years later, and spinal cord strokes are often not quite as fast and severe, or not quite as fast and clear cut as strokes in the brain. So sometimes, especially years later, this can be difficult to sort out, to even put things in the right clinical context in that regard. And then, as Dr. Murphy was suggesting too, there are, a couple imaging findings that we use long-term that would be more common in a spinal cord stroke as a residual, less common in transverse myelitis, but these aren't entirely specific for the most part when we're talking about the damage that's been done in the spinal cord and looking later on after the event itself. So I think it's important to try to sort that out, and if it was transverse myelitis or spinal cord infarction, even if it was many years later. However, if whatever the spinal cord signal was is basically gone, or it's just left over with a little bit of faint residual damage anyways, and the patient doesn't have autoantibodies suggesting a high risk of recurrence for inflammation, it is a little bit academic at that point anyways. Thankfully, because the risk of recurrent spinal cord stroke is incredibly rare, and I've yet to see a true case of recurrence that wasn't within the immediate time frame of the initial sort of onset of spinal cord stroke symptoms.
Yeah, well, you just got to my next question. What is the odds of a recurrence of a spinal cord stroke? So way to go. Thank you for that. Yeah, very, very good information there. There's a kind of, as we're closing in on the last 10 or 15 minutes, there was a question that came in just now. I think it's kind of been spoken to, but in terms of the recovery process. The question really is, for the spinal cord strokes, can bowel and bladder dysfunction improve over the years, like motor function can? Or do you expect that kind of dysfunction, bowel and bladder, to either progress or improve differently, plateau, just kind of improve differently over time than motor function? Dr. Murphy, can you speak to that?
I think that's a really good question, and it's something we commonly get asked at the clinic. And definitely from our experience, bladder and bowel symptoms tend to be annoyingly stubborn compared to other symptoms that patients have. So often with rehabilitation, patients' walking ability improves, their sensory symptoms, numbness improve, but often people tell us, years after the event, their bladder or bowel function reached a certain point of improvement and then hasn't improved much further. And we don't fully understand why that is. It may be because the nerve pathways controlling those things are very sensitive and highly complex, and the injury to them is more difficult to repair. Another important factor is that it's very difficult to rehabilitate the bladder and the bowel. So we have very good strategies for rehabilitating motor and sensory function with repetitive activities, for example, whereas those things just can't be applied in terms of bladder and bowel care. So for whatever reasons, it is quite well recognized that bladder and bowel function can be more difficult to recover over time. But the good news is that there is constantly improving strategies for managing those symptoms, whether that's medications orally. There's now bladder Botox injections that can be done for certain types of patients, and various surgical approaches to manage bladder function. Similarly, for bowel function, there's a huge variety of treatments that vary from medications to surgical approaches in severe cases. So I would encourage patients with those kind of difficulties to engage with their neurologist or physical medicine and rehabilitation specialists, their bladder specialist, if they're seeing one, their urologist, that's termed, to try and manage those symptoms better if they're still troublesome many years after the event.
Mm-hmm. Thank you for that. I think that that's an important point, and really a major part of the recovery and disability over time with patients with whether it be transverse myelitis or spinal cord stroke, that often is difficult to work out. Dr. Zalewski, there's another question that just came in asking about the recovery process and treatments. And I said that they had been diagnosed a few years ago and have a lot of sensory problems, and that their physician recommended acupuncture and electric stimulation. And so, that was in addition to physical therapy. Have you found that can lead to improvement, or is there any evidence suggesting that that can help sensory issues with spinal cord stroke or vascular myelopathies?
A good question. I don't personally have experience with acupuncture and relating to spinal cord strokes and whether or not that does help patients symptomatically or not with the residual symptoms. In general, that would be in the category of alternative medicine, of which I'm not an alternative medicine doctor, but I do think that with these residual symptoms that people are often suffering from, it's a fairly harmless thing that if they find that stimulation helpful to kind of tune down the amount of numbness, tingling, or pain that they have by activating different sensory pathways through with either acupuncture or other modalities, I think those are harmless things to try if it does help provide good improvement for quality of life. Sometimes patients can't tolerate it, but if really the numbness and the numbness pain type component is really the main residual things, I think gradually increasing neuropathic pain medications I found most successful for that type of uncomfortable numbness with, for example, gabapentin. Again, all these things are sort of off-label and with no great data to support, but I have mainly found medications in that class, or even trying something like a spinal cord stimulator may be most helpful in those people with residual severe pain despite quite extensive time in rehabilitation and doing everything they can on their own to help out with that.
Yeah. Dr. Murphy, do you have anything to add regarding kind of alternative, let's call them alternative treatments for these kinds of sensory issues after spinal cord stroke?
I agree with what Dr. Zalewski has said, that we sort of have a couple of routine treatments that we go to, but often we do find that patients find other strategies useful. For example, acupuncture, some of our patients have reported has been helpful, and then different types of therapies, aquatherapy, massage therapy, and various things. So I think for somebody with chronic symptoms, it can be worth trying different approaches just to try and get the best balance and control of their symptoms.
Yep, that's great. We're closing in on the last 5 to 10 minutes of the hour for the podcast. And before we get into our final thoughts, I am wondering, a question came in, is there any registry or database that either of you know about specifically for spinal cord stroke or these vascular myelopathies, where people are trying to research or learn more about these kinds of patients? Is there anything specific to that you know of? Dr. Murphy, can you speak to that if there's anything?
Well, as far as I'm aware, there's no national database as such to track these disorders in a population or a region over time. But many specialists who deal with these kind of rare disorders keep their own internal databases. For example, here at Johns Hopkins, we record databases regarding patients with various causes of spinal cord disorders, which allow us to track things over time and utilize data for various research studies. And I imagine Dr. Zalewski's group at Mayo Clinic has similar protocols there. So if the patient is seeing a neurologist with expertise or interest in these rare disorders, they may be able to opt to be involved in some of these sort of research databases.
Yeah, Dr. Zalewski, do you know of anything that would be specific to spinal cord strokes? Other than, I know that the Transverse Myelitis Association, the TMA, does include these in their kind of general registry, but I'm wondering if there's anything more specific that you know of.
I'm not aware of any other national registry specific for spinal cord stroke. So basically, as what Dr. Murphy has been saying, usually institution-specific collections of these more rare spinal cord disorders is usually the way things go in this situation.
Hey, great. And just to point out to those in the community who are listening, the TMA does include these spinal cord stroke patients within their registry, kind of a spinal cord disease in general. So if you do want to learn more, want to contribute your story and your information in any way, feel free to reach out at myelitis.org and learn more about the registry. So as we're getting into the end of the podcast, wanted to turn it back over to you, Dr. Zalewski and Dr. Murphy, for any final thoughts you have about understanding spinal cord strokes and what that means from the patient and family level. Dr. Zalewski, would you like to start with your final thoughts?
Sure. Yeah. From my perspective, I think right now one of the main unmet needs that people like Dr. Murphy and myself have been working towards is first improving the recognition and diagnosis that these patients that have a spinal cord stroke are different than those that have inflammation of the spinal cord. And that's important to recognize to make a step forward so that we are ultimately working towards more specific treatments, more specific acute management of these patients to give them the best possible outcome and not simply labeling everything that affects the spinal cord as, quote, transverse myelitis. I think that's not only important for spinal cord stroke so that we can work towards better treatments and data to see what does best help patients that are suffering from the spinal cord stroke, but also to help patients that have transverse myelitis so that we're not including a bunch of people who had spinal cord stroke and studies of transverse myelitis and saying, gosh, why aren't these people having improvement like we'd suspect with the treatments we're giving for inflammation? And so just to reiterate, I just think it's very important that as physicians, we get better at, in the initial setting, diagnosing this so we can help patients for the best possible outcomes, and so that we can continue to help move things forward for better treatment and optimal outcomes for patients that have a variety of different spinal cord diseases.
Yeah. And Dr. Murphy, do you have any final words to sum up our conversation today?
Yeah, I think I would be looking towards the future quite positively in terms of progress with spinal cord strokes and transverse myelitis. I think in recent years we have become much better at recognizing these disorders, and now that information is being disseminated amongst the wider neurologic community outside of sort of centers of high expertise in these particular disorders. The idea is that by sharing our experience and data, we can improve diagnosis across a wide range of locations for patients with these kind of disorders. And as Dr. Zalewski mentioned, improving diagnosis is a key element in terms of identifying future potential treatments or improvements in the prognostication for these types of patients, and planning everything from rehabilitation to long-term treatments and future monitoring. So I think we've made a lot of progress in recent years, and that there's certainly more to come, but it's an exciting area to be working in, and to get the privilege to work with patients who have often been hit by quite a severe neurological injury, but often show great bravery and attitude in terms of recovering and adapting to life after that.
Great. That's great. That's a great summation. Thank you, Dr. Murphy and Dr. Zalewski, so much for your time and your expertise today. Thank you to the community and your astute questions, and for listening today. And also to the TMA for allowing this forum to help have conversation and educate others on these diseases. And so with all that, thanks to everyone, and I hope everyone has a great rest of your week.
Thank you very much for having us.
Thank you.
Thank you so much.